Hello, I'm Mark Painter, and today I'd like to talk to you about coding for HIFU in 2021. As many of you know, we did get a new code for 2021, and that makes life easier and also a little bit more complex as we go through everything. Today, I'm going to run through first what we know, the new CPT code, facility payments, how they were set up by Medicare, and any coverage decisions that we have out there. And then I'm going to stop and talk a little bit about considerations because as we look at where HIFU is on the coverage side, we see that it's not really matching exactly where everybody's using things. And as you know, coverage and coding are two separate things, and you need both in order to make it sail through the insurance side. But there are also, of course, ways to work within the system and still provide services to patients who want them, if in fact they can, you can work with them directly. So first up, here's the new code, the 55880. And you can see how it reads. It does include ultrasound guidance. And so as they listed out within CPT, it's the ablation of malignant prostate tissue, transrectal, with high-intensity focused ultrasound, or HIFU, including ultrasound guidance. It is an active code, and it does have a 90-day global. Now, you'll see from the modifier usage down below, it does not allow for co-surgeons, bilateral, or assistant surgeons. There are some situational modifiers that it could be used with, although those would be viewed as highly unlikely by Medicare. So that is one of the things that you want to be aware of, that if you were in fact to provide HIFU in addition to another procedure, there may be some allowances there. But right now, when we move down to what the correct coding initiative bundling edits look like, we don't have HIFU included in any other bundles, so we really won't need to look at modifiers 59 or some of those situational modifiers. Not that HIFU is done frequently with any other procedure, but just so you're aware of that. It does have a medically unlikely edit of 1, which means that in any one date of service, you can only bill the code once. It is a data service edit that is based on policy, which essentially means that it is not something that you can appeal within Medicare to get paid more than once on a single data service. So it is an all-inclusive for the ultrasound, and you can see that based on the CPT description, the ultrasound guidance code 76942 is unbundled, is bundled as part of the correct coding initiative. But there are allowances to allow that to be charged separately if it in fact is used for something other than guidance for the HIFU itself. Again, hard to see that as a possibility with most of what I understand happens on a typical HIFU case. But if you were to be doing some other type of ultrasound guidance on the same day, not related to the HIFU, that would be allowed with a modifier. And then for the relative values, you can see that they did assign a work value of 17.73 for the HIFU procedure. Again, it is a 90-day global, so that includes all the work pre, during, and post-operatively for those 92 days of the global, which includes the day before. And then you can see that essentially it is not really set up from an RVU standpoint to be charged in an office setting. And you can tell that by the fact that the non-facility and the facility practice expense RVUs are the same. Now, there is, from an overall perspective within Medicare, the possibility that this can be charged at the office or in an office setting with place of service 11, but payment for that, if it is in fact covered by Medicare, would not automatically come with the use of the 55880. And in fact, the computer would process it saying that there should be no extra payment. Now, there's a couple of folks that may try and work with a payer directly to try and get paid a little bit extra for the facility itself or for a full amount extra, but that is going to be kind of around the contract or around the agreement with Medicare. So that's something that obviously is a Medicare rule, but because of the widespread use of the RBRVS, it is also something that if you are planning to work with your private payers, you're most likely with your contracts going to be looking at a carve out to get paid in place of service office. So that's kind of one of the things you want to watch as you're going through and looking at each of these. Now, when we look at the facility side, this is where there has been several discussions. The folks working with HIFU and I've been involved with some of those across some of those groups as well. Really, we're looking for an APC group that paid at a higher level. Information was submitted to Medicare directly to try and get this APC changed. It didn't happen this year, so I know lobbying efforts are continuing here, but that APC rate for both the ambulatory surgical center and the outpatient hospital setting are certainly disappointing in the way that Medicare made those decisions. So when you're looking at traditional Medicare, and if you were to, number one, charge this with a place of service with outpatient hospital system or ambulatory surgical center, and if it was covered, then these would be the payment rates that would be provided for the facility, in addition to the previous slide when we looked at the payment rates for the physician. And these are unadjusted national levels, so they'll vary a little bit by area. So next, I'm going to jump over a little bit into coverage, because HIFU was non-covered for a number of years, and of course we didn't have a CPT code until this year. But what we do have is at least one one of your Medicare payers, NGS, that offered up a coverage decision, an LCD, for last year in April, and specifically for HIFU. When we look at what the coverage rules are for NGS, and by the way, this is the only LCD that we were able to locate, that it is a whole gland HIFU, is considered medically necessary as local treatment for recurrent PCA, prostate cancer, following radiation therapy, when all of the following criteria met, that you do have a biochemical reoccurrence, you're positive for post transrectal ultrasound guidance of the biopsy, the patient is a candidate for local curative therapy as evidenced by favorable clinical and pathology factors, and it requires one, that its clinical stage is T1 to T2 NX or N0, and that the PSA is less than 10, absence of distant metastases, no lymph node involvement, interval of biochemical failure is greater than 18 months, and then from the ISUP, its grade is less than 4, and that there is a local reoccurrence that you can identify that you are able to destroy. So those are some of the criteria that they put in place. Now, They did make a change last year, moving all of the coding instructions from the LCD to the LCA. So when the new code was adopted, you'll see that the local coverage article, which is what an LCA stands for, is what needs to be amended. They did not change the LCD, which talks about general coverage for HIFU itself, but they did update the LCA with the effective date on 1/1/21, and that was specifically to accommodate the new code. It used to be the 55899, and ultimately that was covered for those patients fitting the criteria listed in the LCD from 4/1 to 12/31. Then beginning 1/1, the appropriate reporting would be the 55880. The following codes, and you can see that they are all three required: the C61, the R97.21, and the Z92.3. So if you have all three of those, you meet the criteria, then NGS considers that to be a covered service. Now, when we look at this from the perspective of other Medicare carriers, there are a number of Medicare carriers. They can't do a blanket non-coverage decision with new codes, but they don't necessarily have to cover a new code simply because it's included in CPT. So what we're seeing right now is there are a lot of payers, or a lot of Medicare carriers that are still considering the HIFU as a non-covered service. That may be changing as they move through the process. And the reason that's important is that as a non-covered service, if that is in fact their overall conclusion, you are now allowed to charge the patient directly and are not governed by any of the Medicare payment restrictions. And I'm going to go back to the limiting charges that are in place now for, excuse me, I went back a little too far, the non-participating and the limiting charges that are part of the overall process relative to coverage rules. So if it is a non-covered service and you need to check with your payer, your Medicare carrier, I'll talk about private sector payers in a minute, but you need to check with your Medicare payer to make sure that it is non-covered, or if it is covered, under what circumstances it is covered. If in fact HIFU is a non-covered service, then the limitation rates for participating and non-participating physicians are not applicable, and you don't need an advanced beneficiary notice in order to provide the service to the patient and charge the patient. If, however, the HIFU is covered in some cases, it is now subject to coverage rules, as Medicare is now saying we cover this, but only under these circumstances. And because of that, and because of some of the unknowns surrounding this, we would highly recommend that you obtain an advanced beneficiary notice from the patient, even though it may not be necessary based on whether it is covered or non-covered. So get an ABN on your patients. I think that's the smartest move in case you find out that Medicare is going to cover this, but they are going to follow the NGS rules, making it a very restrictive coverage policy. So take that extra precaution of getting the ABN signed by the patient before they have the HIFU procedure. If it does remain non-covered, again, you can charge based on what you feel is appropriate, and you're working with the patient for payment if it's non-covered. If it is covered under certain circumstances, you will be subject to Medicare charge limitations, and you can see where those are with the participating and the non-participating fees, depending on your status with Medicare for that particular service. But again, with an ABN, you're likely working with the patient for payment of that procedure itself. When we consider this from the facility side, again, if it is covered but only under certain circumstances, and you are in a participating Medicare facility, then you are subject to the rules of Medicare, just like you are with your professional service fees. You'll need an ABN if it's a participating facility, and so if it's covered, they will be subject to the payment limitations that are in place, whether it fits the coverage guidelines or not. If you are, and so you've got some of the same restrictions there relative to coverage. If you're in a non-participating facility, not a non-participating facility, but a facility that does not or has opted out of Medicare, so it's not a part of the Medicare program. Medicare doesn't have a way to govern that particular facility setting. That now becomes patient responsibility. You don't have the ABN rules for the facility. Now, the physician, even though they're in a facility that's not a part of the Medicare program, either as a non-par or a participating facility, the physician could still be a participating physician. The physician would be subject to Medicare rules as they exist, but the facility itself, which is now outside of the system for Medicare, is now working directly with the patient. There's no necessity for an ABN, but again, you'll want to make sure that you have arrangements set up with the patient, knowing that they are going to be responsible for the facility charges in full, or whatever deals you make with the patient directly. The other thing to consider, there are a couple of different spots within the Medicare regulations that talk about the place of service. As you know, a typical place of service for the ambulatory surgical center, and it's listed specifically as a participating ambulatory surgical center in some of your carriers, and in one part of the carrier's manual is 24. And then if you look at further down the road, there's some argument that if it is a it's not a participating ambulatory surgical center, that the place of service you might consider is 99. That is something you're going to want to check with your carrier locally to find out what's appropriate for the place of service for both the physician and the facility charge, if in fact that gets submitted on behalf of the patient, because they would like to see the denial. So there's a little bit of work to do understanding the coverage rules and where it falls within the Medicare program. When you're looking at the private sector, we all know that Medicare is a foundational payment structure for a lot of private sector payers. But that doesn't mean they have to follow coverage rules, nor do they have to follow the payment rules exactly. And in fact, a lot of them do not. So when you're talking to a patient who has coverage under a Medicare Advantage plan or a private sector payer, you're going to want to check with the payer first. You may want to look at a carve-out within your contract that would pay appropriately for both the service and for the facility, and negotiate with them what coverage rules are in place. And you'll need to keep in mind whether or not those payers, and there are a number of payers that have grabbed the NGS rule, especially those that offer Medicare Advantage plans within the NGS jurisdiction, that you're going to want to take a close look at what they have in place. Best place to check that is on the payer website or through your provider bulletins to see what kind of coverage indications are out there. And again, you may have to discuss some of this directly with the payer in order to find out what the payment rates are, what the coverage rules are relative to each one of those payments. So again, I just kind of want to go back as wrap up. Yes, we have a new CPT code. We do have appropriate values for the code, and we do have established fee schedules for the facilities. As with anything, it may not have come out to our liking, and you may have to navigate around some of those issues. And of course, as you look at the coverage rules, and I would keep an eye on all of your individual carriers to see whether or not they're going to follow NGS moving forward or not. But I would check with each one of my payers before providing this service to find out where my coverage is, where the patient's responsibilities lie, and juggle that with your charges as well as your reimbursement activities relative to the patient who would like to receive this service. Hopefully that gives you a reasonable approach to looking at HIFU for 2021. And as with all of this, we will continue to keep an eye on the payment structure that's out there. And through PRS, we'll publish updates as we see them. And of course, you can check with your various coding sources. And today I used Coding Today, or AUA Coding Today, for the information. Thank you.